All right, good morning, and thank you guys for allowing us to present on robots and trauma surgery. You don't have any disclosures. So MIS techniques in trauma surgery have been very slow to adopt. The transition to laparoscopic and robotic techniques has been slow to evolve as well. Here we just show the robotic platform being used to repair two diaphragmatic injuries that happened in a blunt setting, one of them with a pericardial rupture. So our first case is a 31-year-old male who was involved in an MVC. He was the driver and was T-boned on the passenger side. He had a right diaphragmatic injury that was visualized on CT imaging that you can see here. He also had a grade 2 liver laceration, a grade 2 right renal laceration, and remained hemodynamically stable. He underwent urgent surgery within 9 hours of his presentation. So robotic ports were placed horizontally across the abdomen just above the umbilicus. Upon initial evaluation of the abdomen, we noted a traumatic avulsion of a portion of the falciform ligament. Using bipolar cautery, the remainder of the ligament was taken down for adequate mobilization of the liver and visualization of the diaphragm. The liver was then cauterized from the prior avulsion. Next, the liver was bluntly reduced from the right thorax with bipolar and Caudier forceps. At this time, we had discussion with anesthesia, and given our pneumoperitoneum, the patient was starting to experience tension physiology. Our insufflation pressure was then lowered from 15 to 8 millimeters of mercury, and the patient was able to tolerate this pressure well. We noted a moderate amount of hemothorax, and given this, a suction irrigator was used to evacuate the thorax and wash out the thorax as well. And after complete evacuation, a chest tube was placed by the bedside assistant and was clamped, and we repaired our diaphragmatic defect. So with adequate reduction of the liver using the third arm, we proceeded with closing our diaphragmatic injury using a zero-barbed permanent suture. We began our repair from the medial aspect of the injury, and at our facility, we only had the choice between a 6-inch and an 18-inch barbed suture. And given our defect size, we elected to use the longer suture, however, had significant difficulties given the length and the space that we were working in. So in the future, we would recommend using a shorter suture length, either a 12-inch or a 9-inch, or really whatever would fit your defect size. So once the defect was closed, we oversewed the lateral aspect, locking the suture in place. We were then able to evaluate the remainder of the abdomen and the liver laceration itself. And here you can see our final result. So the patient was actually extubated and taken to PACU. You can see his postoperative chest x-ray on day 1. He had minimal output, and his pain was well controlled, and he remained on room air. On post-op day 2, his chest tube was placed to water seal with subsequent removal on post-op day 4, and was discharged home on post-op day 6. So for our second case, this was a 46-year-old female who presented similarly. She was the restrained front seat passenger and had a right diaphragm rupture as seen on the CT imaging here. She also had right 3 through 6 rib fractures, pelvic fractures, and also remained hemodynamically stable during her initial presentation. She was able to undergo urgent surgery within 30 hours of presentation. So, once our ports were placed in a similar fashion across the abdomen, upon entry we noted a 7 by 14 centimeter defect of the pericardium. Given the size of the defect and partial herniation of the right atrium, intrapericardial IVC, and no contamination, we consulted our cardiothoracic surgeons who recommend placement of a dual-sided EPTFE mesh for repair of the pericardium. Given the difficulty with the exposure, location, and mesh placement, the falciform ligament was further mobilized using electrocautery. Once adequate exposure was obtained, the mesh was sutured in place circumferentially using a zero-braided permanent suture in a simple interrupted fashion. The decision to close the pericardial defect was to prevent future complications of cardiac herniation with strangulation resulting in potentially fatal arrhythmias, myocardial ischemia, or cardiac arrest from acute disruption in preload. While not seen during this case, the phrenic nerve can be found over the lateral aspect of the pericardium. There was question as to if the phrenic nerve itself in this case was preserved given the size of the injury, although no evidence of diaphragm paralysis or symptoms of phrenic nerve injury was seen postoperatively. So once the mesh was sutured in place, we then used our barbed suture that had been previously started in order to close the remainder of the diaphragmatic hernia, or diaphragmatic rupture. And after completion of our diaphragm repair, hemostasis was obtained and the abdomen was subsequently closed. Here are our final results. So this patient's postoperative course, she was taken to the ICU postoperatively, although it was extubated and remained stable, but it was more for hemodynamic monitoring given her pericardial rupture. On post-op day 1, she underwent an echocardiogram that did not show any effusion or valvular abnormalities. You can also see her post-op day 1 chest X-ray here as well. The echocardiogram was really just because she had some ectopy noted on her continuous EKG. On post-op day 2, she had her chest tube placed a water seal and was subsequently transferred out of the ICU and had her chest tube removed on day 3. On day 14, she was discharged home after repair of her orthopedic injuries in coordination with home nursing. So in conclusion, MIS and trauma surgery has been slow to adopt minimally invasive techniques, but robotic utilization in trauma is not only feasible, but it has improved visualization, it has the ability to allow for complex injury repairs, and can be performed in an urgent setting. So thank you, and I'll take any questions.